We're the co-chairs of NAPACSL's Special Committee on Anti-Asian Bias and Xenophobia. Before we get started, I'd like to go over a couple of housekeeping items. Today's webinar is a platform for information exchange and engagement, so we do encourage your participation throughout the next hour. Please feel free to type your questions and to answer any questions in the chat box on your screen. We will hold a formal Q&A after our speakers are finished presenting. I will also ask that you please mute your microphone during the presentation. So let's get back to why we're here today. The media have reported on some of the anti-Asian bias and hate incidents directed at our community since the start of the COVID pandemic. Still, we know that racism impacted our AAPI communities long before the arrival of COVID-19 through undertakings like the Chinese Exclusion Act, the incarceration of Japanese Americans during World War II, and the murder of Vincent Chin, just to name a few. Today, we'll hear the latest data on anti-Asian bias and hate incidents, learn how racism is a public health crisis, and hear suggested policy recommendations on how to address this issue. I want to thank our sponsor Amgen for supporting NAPACSL and for supporting this important webinar. Representative Lee, I'll turn it over to you to introduce our speakers and our first presentation.
Thank you, Representative Santos, for that welcoming. Hello, everyone. Minnesota State Representative Fu Lee, and I'm happy to introduce our lineup of speakers. Presenting today are Cynthia Choi, co-founder of Stop AAPI Hate, Dr. Emir Shah, the Washington State Secretary of Health, and Dr. Anthony Chen, the Tacoma Pierce County Director of Health. In the interest of time, I won't be reading their bio, but it will be provided in the chat box for all of you. Cynthia, thank you for joining us. Please begin your presentation.
Thank you, Representative Lee, and thank you to NAPACSL for inviting me to share with you our latest numbers and the health impacts, but most importantly, what we can do about it. So thank you again for the honor to address you today, and I'm going to go ahead and share my screen. And if you could give me a thumbs up that you can see that. Okay, great. Thank you so much. Okay. Oh, so today what I would like to do is to talk to you about Stop API Hate, to share with you our latest numbers and findings, public health implications, and what we are recommending that how we can respond to incidents of hate and bias. So just a little bit about our coalition for those who are not familiar. We started Stop API Hate in March of last year. Collectively, our organization at Chinese for Affirmative Action, APCON, which has now been renamed to AAPI Equity Alliance, and Asian American Studies Department at SF State University. Collectively, we have over 150 years of serving our community, having the trust, and doing work to advance racial equity. Our mission is to advance equity, justice, and power by dismantling systemic racism and building a multiracial movement to end anti-AAPI hate. So just as wanting to, before jumping into these statistics, we wanted to share with you, as my colleague Manju shared early on when we started reporting incidents of hate, of what COVID-19 related racism looks like. So as you can see, these are real people who shared stories about their harrowing experience that they experienced, their child or their elderly parents, in the workplace, on the streets, and when seeking medical assistance by a professional. I wanted to share with you that, again, these are individuals who were directly impacted. One of the stories that stands out for me is the fact that even while seeking medical assistance, healthcare professionals were treated with discrimination, patients who refused to be served by medical professionals because of fear that they might catch COVID from that provider, to other patients attacking, verbally harassing other patients. And so this is something that obviously we've been able to demonstrate has had a real impact on individuals, and was really important for us to lift up. So what do our numbers share? We just recently shared that from March of last year to September of this year, we have received over 10,000 incidents. And we have higher numbers being reported this year than last year, which demonstrates to us that this issue is not going away. It continues unabated, and it is having a devastating impact on our communities. We are seeing very similar patterns to what we reported earlier, that we have all Asian Americans and some Pacific Islanders are reporting to our site. But as you can see, that some of the top ethnicities are Chinese, Korean, Filipinx, Japanese, and Vietnamese. But we are receiving reports from other communities as well who are, again, being blamed, being profiled, being verbally harassed. We also tracked the types of hate that our communities are experiencing: verbal harassment, shunning, in some cases physical assault, online, being coughed at, spat on, hostile workplace, and denied entry and service. And then we also looked at the location, the sites of discrimination, to help us better understand where this was happening. So majority of the incidents, as you can see, are happening in public settings, on the public streets, in people's neighborhoods, in businesses, while people have been going grocery shopping, getting their medications. And then you see also online, some incidents on public transit and schools. And keeping in mind that this was all happening while many of us were sheltering in place, but we also know that there were members of our community who didn't have the privilege of working from home. They were frontline workers, food delivery drivers, healthcare providers, essential workers that were particularly vulnerable to incidents of hate. I wanted to share with you that we have also been tracking the mental health toll challenges that our communities have endured. Obviously, we are experiencing a national mental health crisis, but for our communities that have been targeted, directly victims and survivors of these incidents, there is additional stressors and that have resulted in the effects of, typically some of the symptoms that we've seen with those who PTSD, and those displaying effects of racial trauma. So we have incidents or high rates of people reporting that COVID is actually less of a stress than the actual racism itself, an indication that this has been, again, a devastating impact in terms of the mental health toll that is particular to our communities. So one of the things that I think is really important for us to lift up is that we did a national survey of over 1,000 AAPIs, and we oversampled Pacific Islanders because we didn't have as many reporting to our site. And we asked them, what do we think the number one response should be in terms of the surge in anti-Asian racism. And what we found is that the top three recommendations were education, community-based solutions, and enforcing civil and human rights. And you can see that law enforcement, follows that. So this is actually was really reaffirming to Stop API Hate, because in fact, these are our recommendations. And to see that there's actually widespread support in our community for this was really affirming and heartening, and affirmed that we were on the right track. So what we wanted to do was share with you some examples of what we're trying to do in California. We started in California because of the fact that Stop API Hate received significant state funding as a result of the legislature in California pushing for increased investments to address hate in the state. And that is because over 40% of the incidents were coming from California. And so we were able to make a case to our governor to make investments that address the immediate needs of victims and survivors, but also makes investments in prevention and other strategies. But let me start with our state recommendations, because I think it speaks to the fact that we are taking a public health approach to addressing racism. So, and it's based on our data, and it's based on particular parts of our community that are vulnerable. So one of the statistics that I wanted to share was that over 60% of our respondents were women. And so we took a particular look at that issue, and the fact that other vulnerable communities were disproportionately impacted. So with this knowledge and with the data that we had, the public health framing, a gender-based approach, and the fact that a majority of the incidents were happening in public spaces, we recommended the following. One is that we have a legislative policy framework that is focused on preventing street harassment. For many women and other vulnerable communities, street harassment and the issue of street harassment has been normalized. And so we want to take this on as a major public health issue. That we require gender-based approach to addressing rider safety on public transit. This was also another site of location where riders experience discrimination and hate. And again, not just the API community. And we wanted to direct the California's Public Health Agency to lead a statewide effort to prevent and respond to hate in public spaces. What this has also meant too is that where we saw incidents taking place in private businesses, that we wanted California to strengthen its civil rights protections to address hate in businesses. And this is based on the fact that we saw the AAPI community being harassed in stores and in restaurants. And this was taking place between customer to customer. So we do have laws that essentially protect individuals from being refused service or accommodations by businesses, but we don't have very many, we don't address the fact of what happens when a customer harasses or attacks another customer in a private business. So we want to take the approach of piloting programs and initiatives that really engage the business community. Again, not small business owners, but larger big box retail, so that they are creating a safe and welcoming place for all customers. I wanted to mention too, and this is what I referenced earlier, is that earlier this year, because of the data, because of our advocacy, over 150 community-based organizations joined Stop API Hate to push for a historic $166 million investment that goes not only to the AAPI community, but other affected communities. And it is not just focused on victims and support services, but also around data, because the data equity really helps us to understand how we can address racial inequities, that we really focus and center on healing, prevention, and addressing hate wherever it shows up, whether it's in the schools, in the workplace, in public, and that we have a holistic approach. Government has a role, community-based organizations have a role, as well as the private sector. And this is the work that we will continue to advocate for, that it's also not a one-time investment in our communities. So that's it for my presentation. I just want to say thank you for this opportunity, and I look forward to any questions that you have, and any future partnerships.
Well, thank you, Cynthia, and thank you again for the work that Stop AAPI Hate has done for all of us throughout the country. And just looking at your presentation, there's a lot of for us to take away for, especially here in Minnesota, and so I really appreciate that. And now I'd like to turn it over to my colleague, Hawaii State Representative Ryan Yamane, to moderate the next portion of the presentation.
Okay, thank you, Representative Lee. Hello, aloha everyone. I'm Hawaii State Representative Ryan Yamane, and I serve as co-chair for NAPACSL's Health, Human Services, and Housing Committee. I have the distinct pleasure of welcoming Dr. Umar Shah and Washington State Secretary of Health, and Dr. Anthony Chen, the Tacoma Pierce County Director of Health, to the webinar and asking them a few questions. So I'll start with Dr. Shah. We just heard about the alarming number of biases and hate incidences directed at AAPIs. Will you please elaborate on how these types of incidents impacts public health beyond the obvious impacts to those that are directly impacted?
Thank you. Can you hear me okay first?
Yes, very good.
Perfect, perfect. Well, first of all, thank you all for having me join this incredibly important panel. And I do want to thank Cynthia for that presentation, because I think what she's done is really highlighted the challenges, both from perspective of data and information, but also the impact on real human beings, real lives, real people. And we have to always remember that this isn't just about the numbers, but each of those numbers, each of those dots represent an individual who has a family, who has a community. And ultimately, when there is a hate-related incident, that has an impact, a profound impact on that entire ecosystem. So I did want to start by saying that, and also I wanted to say it's great to be with Dr. Chen, an incredibly just an amazing voice in both public health, but also in this real challenging time of incidents that none of us would like to have in our country, but unfortunately continue to persevere. So Anthony, great to be a part of this panel with you. I wanted to just maybe take a step back and just remind everybody about two things. One, I'll give a quick background for me that might give a little bit of context for my perspective. And then number two is really why this is a public health concern. So the first is that I'm originally from Pakistan, Asian American, true and true. Have spent the last 25 years in Texas, in Houston, and was a part of a number of different efforts that were really a part of the Asian American Pacific Islander community, not just locally, but also nationally, including with the South Asian Public Health Association, SAFA, as well as the Asian American Pacific Islander Caucus at the American Public Health Association. I served as the president of SAFA previously, and have really very much engaged in work that's happening within the API community, especially in Texas. Now, as you can imagine, after so many years of doing work in Texas, Governor Inslee asked me to join as the Secretary of Health, and I'm just about 4 days away from being 1 year on the job, just after vaccines arrived. So it was a really interesting time to, in fact, everything appears to be vaccines and pandemic and vaccines and pandemic. But in the midst of all this, what that background, why I bring it up is that when last year we were in Houston and the laying out, the rolling out of what was occurring in our Asian American communities, especially particularly our Chinese American community, I have to be honest, it was quite scary. We had a 60+% decrease in people visiting in Chinatown in Houston. We had loss of businesses. We had not just implicit, but we had overt bias, discrimination, and racism that was put towards community members. We had people who were even subjecting that to the children of whether they were immigrants or frankly, people who were not immigrants, but just appeared in someone else's eyes to be someone new to the country and may have lived here for decades. Their children were impacted, their families were impacted, their livelihoods were impacted. That is something that we need to really be thinking about very significantly. It happened previously with Muslim Americans, South Asians, as we all know after 9/11. It has happened with our Sikh community, our Hindu community. It has happened with so many communities across the spectrum. This is a hate-related issue, a spectrum of discrimination that we have to systemically be thinking about. So let me go to the second point, which is the public health part of this. Why are we so passionate? Why are the Dr. Chens and the Dr. Shahs of the world so passionate about this issue? Not just because we are members of the community. That's absolutely true. However, we also see ourselves as role models as part of the solution. We see this as not just individuals individually being subjected to these discriminatory or other kinds of hate practices, but we see a solution as far as how do we look at this from a broad population health perspective. That there are so many aspects of this that are not just about the individual, but it's really about the very currents of how our society is set up. And what are the discriminatory and other kinds of practices that are leading to Asian Americans having health inequities, health disparities, whether in cancer, chronic disease, behavioral health, the negative bias, the microaggressions, the hate crimes, the vandalism, all of that is absolutely linked alongside with stress and post-traumatic stress, depression, anxiety. But it all comes together with this one last point. In order to address these things, we have to get to the root causes, but we can't just be thinking about individual by individual, community by community. We have to be thinking about this as a robust population health perspective, because this is not just about the individual. This is about the individual being part of a community and ultimately a state, ultimately a nation, and ultimately a globe where we continue to have not just these issues, but the solutions will also need to be a part of that. So let me stop there, and I hope this is helpful, and I will turn it back.
Okay, thank you. Thank you for that. Now, this question is for Dr. Chen. Chinatowns and AAPI business districts across the country have experienced targeted vandalisms and downturns in businesses even before COVID-19 was discovered in the US. Will you please share your thoughts about the intersectionality of the COVID pandemic and internalized and institutionalized racism? Dr. Chen?
Thank you, Representative Yamane. Right, I mean, the anti-Asian attacks and racism are not new. I mean, they are layered on longstanding themes in the US culture about the yellow peril, the model minority, the perpetual foreigner, and yellow fever, also known as Asian fetish, right? And besides physical harm, those attitudes, as well as these attacks we've heard about, cause fear and stress, especially among our elders and women. And when you think about the racism, doesn't just harm the individuals, they harm our community at the individual level, the interpersonal level, and the institutional level. And your reference to Chinatown is ironic, because here in Tacoma, there is no Chinatown, because in 1885, the city expelled all of its Chinese residents. 148 years ago yesterday, the Northern Pacific Railroad reached Tacoma in 1873. Chinese laborers were critical to its construction, but we all know they were paid less, they were harshly treated and subject to discrimination. And as Representative Tomiko Santos mentioned, in 1882, the Chinese Exclusion Act was signed. And even here in the state of Washington, there were laws that forbade Chinese to own land or even testify in court against whites. So at that time, there was an economic downturn. And as we see many other similar economic downturns, the white residents blamed the Chinese and they kicked them out of Chinatown. So we have no Chinatown in Tacoma. And in Seattle, Chinatown originally was right in downtown where what we call Pioneer Square was displaced as the white community leaders coveted that land. And then subsequently, the Nihonmachi, or Japantown, was gutted when the Japanese were forcibly removed during World War II. So these are examples of power and policy. But there are also the impacts of culture and acculturation. So, for kind of like this model minority, kind of quiet Asian stereotype is, derives from Confucian respect for authority and hierarchy. We prefer to be quiet and low profile, while, Pacific Islanders, for example, tend to be much more loud and vivacious. Asians tend to be more merit-based, and they, both Asians and Pacific Islanders really value family, right? But then at the same time, we all live under this pressure for acculturation. And COVID-19 has really revealed disparities that are the results of these policies as well as cultural factors. So here in Pierce County, very early on, we found that Pacific Islanders were 4 times as likely to get COVID-19. Latino, American Indian, and Blacks were twice as likely, but Asians were about the same as whites, right? And this probably a lot was linked to several factors. We heard earlier, many of these people work in frontline essential services. They could not take time off. Many of them, because they value family, lived in large multi-generational households. And therefore, if someone got sick, they spread it very quickly. And many of them, because they were lower income, they lived in ratty housing, right? I mean, not great housing. So none of these things really help. And of course, there are high rates of diabetes and other diseases in these communities. So, and lastly, of course, engagement with the healthcare system. There's distrust, as we know, especially like in the Black community and the Latino community. There's access to healthcare. Don't forget, some of our Pacific Islanders are from the COFA nations, and until last December, they were cut out of Medicaid. And so lots of different issues, which has reflected years and years of policies and power, which impacted people. Oh, and the acculturation too, right? I mean, there's just this kind of cultural imperialism where a lot of people, because of colonialism, want to be white. And also, like for the Japanese, many of them are highly acculturated because of the experiences of being treated as foreigners and expelled and sent to camps during the war. So this is all history that has impact on our health going forward.
Well, thank you for sharing, Dr. Chen, and thank you for your background with the Gundam style sharing on that. So this question is actually for both Dr. Shaw and Dr. Chen. Can you describe what the meaning or what the defining factors of racism is in a public health crisis? Maybe we'll start with Dr. Shaw.
Sure. Thank you for that. And I do want to acknowledge that I have a mountain behind me. So I don't have Gangnam style, but I will say that it's very different than Houston, where it was quite flat, as you know. I would say a couple of things. One, picking up where Dr. Chen also left it, is that we have to really be reminding ourselves that we need to help the healthcare system look beyond just the four walls of a clinic, an emergency department, a hospital, that ultimately it has to be what happens in the community. And that focus in the community means that we have to be thinking very carefully about those social, what we call social determinants of health, housing, transportation, education, all sorts of other elements to this. But the reason I bring this up is that this gets to the absolute concern about why we need to declare racism a public health crisis, is because we have to advance health equity across the system. And that health equity approach really means that the first step is to call it out, is to call attention to it. The declaration is a formalized way for government to say, this is a first step to advancing health equity, racial equity, justice, and must be followed by allocation then. And that's usually why the declaration is so important, is that you then focus the resources and the strategy. So it's absolutely about the declaration, but it's what comes after that, is that everybody is aware that you are now going to be focusing the resources and strategies, whether it's how you hire within your agencies, whether you strengthen the partnerships with communities or groups within the communities, whether it's advocacy for policy change. That is what this is all about. Fortunately, there are 8 Washington counties who have officially declared racism a public health crisis and are taking absolute steps to advance racial equity and justice. One of those is Pierce County, is Tacoma Pierce County, Dr. Chen's county. Another is King County, which is where Seattle is, for those who don't know. But we also have other communities like Spokane County and Thurston, Kitsap, which are smaller, or Whatcom County, smaller communities that have also taken this. That ultimately this is about the recognition that racial and ethnic health inequities persist, and they are not just in the healthcare system, they're beyond the healthcare system, and they impact lives. So let me stop there.
Okay, Dr. Chen?
Yeah, so as Dr. Shah alluded to, in June of 2020, the Tacoma Pierce County Board of Health passed a resolution declaring racism a public health emergency. And the racial ethnic disparities in health outcomes are very clear. Your organization, NAPACSL, recognizes that AAPIs, for example, have higher rates of hepatitis B. They also have higher rates of thalassemia and tuberculosis. When I went to medical school, they taught us that hepatitis B was a disease of drug addicts and people who are sexually promiscuous. Nowhere did they tell me that it also is a disease of people who came from areas of the world that had very high rates of hepatitis B, like Asia, the Pacific Islands, Sub-Saharan Africa. Here in Pierce County, Pacific Islanders, in addition to American Indian and Alaska Native and Black residents, have a significantly higher risk of premature death when compared to Asian, Hispanic, or white residents. Asians have a lower rate of mammograms, even though Pierce County has a lower rate than the state average. I mean, so Asians are about 22%, Pierce County is 36%, and the state is 40%. In Pierce County, when you look at poverty, about 12% of children live in poverty, but in Asian children it's 15%. And then when you get up to American Indian Alaska Natives, it's 24%, right? So the cumulative result of all, the history, the racist systems and structures contribute to an unhealthy and unsafe environment for our communities. And every community is different. So for example, here in Pierce County, I mentioned we don't have a Chinatown. There are not as many Chinese here. But we do have a lot of Cambodian people who came originally as refugees. So those of you who know, I mean, the Cambodian refugees who came tended not to be as educated. They had suffered incredible trauma through their journey to get here. And of course, that colors how we are a little different, for example, than from King County. And, I've mentioned the expulsion of the Chinese from Tacoma, and just like many other cities on the West Coast, we went through the time of World War II when our Japanese residents were forcibly removed. And so we must make sure that we address all these levels, all the social, economic, and environmental conditions that produce health, and of course the history that's been layered on, so that we can end the effects of racism on our community members.
Wow, thank you. Thank you for that. I have a question for Dr. Shaw. How do you work with localities that might not adhere to the public health recommendations and might not see how this connects to biases and hate? Do you have any recommendations on how to depoliticize these issues?
Well, I think that's the $1,000,000, $1,000,000,000, $1,000,000,000,000 question right now, is that everything has become so politicized. And, when Dr. Chen and I both come at things, we're coming as public health, but we're also coming as physicians, as doctors. And, I haven't talked to Anthony in a while on this issue, but I'm sure that he will agree. We've never had in our clinical practice the situation where people would frankly say, we do not trust you, as you are saying, give me IV medication for my blood pressure because I read something on the internet about it. And so this real politicizing of where we are as a nation, as a globe, is incredibly not just frustrating and disappointing, but is incredibly divisive and has so much impact on everything that we are doing. And this vaccine planning and prioritization and process is absolutely the latest of this. And our, I think the way we move forward are a couple of things. One is that we start with science and evidence. I think you have to highlight what the facts are. Now, there are many and some who say, well, facts don't matter, but we truly believe facts do matter. So you start with that. But where we have to get better is we cannot stop there. It's necessary, but not sufficient. We've got to do a markedly better job of taking that information and translating it into what really makes sense to people. We can't have our public health or our physician or scientist jackets on, our coats, and say, trust us because we are X, Y, or Z. We must engage communities. And I think that's the key message for us, is that it's not just about what we're trying to do from a governmental standpoint or a policy standpoint, is how do we get to those very communities and those community-rooted organizations, and how do we approach them with the respect and humility, but also engage them in. So here are a couple of examples for just to put it out there. We had been working very closely with Governor Inslee, his entire office, on the importance of COVID-19 language access. So as we were moving forward with our work, we put that work into translation of 36 plus languages, and oftentimes even more languages that are very much about, even when somebody calls our hotline to get information. The teams of specialists that are advising across the system. We funded over 200 community-rooted, community-led organizations, well over close to $10 million in community-led efforts, especially around vaccines. We invested in a caravan set of vehicles that really allowed us not just to be at a state level and say it's not us, but to actually go all across Washington, from the largest community to the smallest community, from the most diverse community to the least diverse community, and be there to engage our community, to be present, to say we are here to help you get access, in this case, to vaccines. So when you think about all of the information that I'm sharing, it goes back to knowing the data, knowing the information, because you have to focus your attention somewhere. And you can't prioritize everything, because you won't prioritize anything. So we focus where we believe the biggest needs are, and then we look at those strategies on how we can work with those local partners so we can advance the needs, the health needs of that community. And then the final thing I would say about this, which is really critical to all of this, is that we have to continue to champion. We must use our seats, our roles, our ability to champion, to scream from that mountaintop behind me. We must do that and be willing to advocate for, ultimately, community. And I think that's what this is all about.
Okay, well, thank you for that. Dr. Chen, let's think a little bit about the cultural appropriate care. What role do you think healthcare providers take in addressing this issue? And what education or information do you think providers need in order to do that? Dr. Chen?
Yeah, I think it's not just education information. There's a lot of other things, and I'll get into that. And I'm really pleased to see that NAPACSL, you do have positions and resolutions regarding data aggregation, cultural competency, cultural humility, language access, and social determinants of health, or the social, economic, environmental conditions that produce health. And the data, it's really important, to lump API data together when we need to get the power, but we also need to be able to disaggregate it and get that information to the hands of people who are working on the front lines. And so for healthcare providers, we need to ensure that they have the necessary racial, ethnic, and cultural education and training so that they can tackle these issues to take care of people, but also to understand they have a role to mitigate the social, economic, and environmental factors that negatively affect community access and health. For the community, it is important for them to have language access. We need to help them address the cultural barriers to care, make sure that they have healthcare literacy, and of course, address the stigma of mental health. The physicians need to also make a fundamental shift that, in healthcare, they're primarily working with individuals on treatment, while in public health, we work with populations and prevention. Physicians need to help bridge that, to start looking at the health of the population and not just the person in the exam room. Physicians also have incredible power and influence, and they can use that to change policies, systems, and environment. And they can be part of this movement and I'll get into, if I have time later, I'll get into it, but we need to do social marketing. We need to be working on a community level. And there's just so many of these issues, whether it's housing, jobs, discrimination, or whatever, that the healthcare providers can really help us with.
Thank you for that. As we wrap up this formal question and answer portion, I have just some final questions for one last question for Dr. Shaw and Dr. Chen. Dr. Shaw, do you have any recommendations for policy that would positively impact health and well-being of the AAPI community?
One thing the state government here did in 2020, Governor Inslee had created an Office of Equity, which is really to serve all state agencies. I think what I said earlier, Representative Yamane, is really very important, is ultimately we have to set the direction. We have to be willing to champion, articulate that importance of this work. But then we have to not stop there. It cannot just be about words, it has to be about actions. And partners see it, others see it, but especially community members see it. The last thing you want to do is to champion something and then just see no action come out of that. And so there's a lot that we have to really work towards when it comes to health equity. But I think the key message for me, especially with policymakers and respected elected officials here, is that we've got to figure out a way to move past the politics. We have to, as a physician, as a health provider, as somebody who's spent my entire career on saving lives, this is not red or blue. This is not left or right. This is not east or west or north or south. This is about all of us. And ultimately, we are doomed to fail if we do not get past those divisions. So I would say, yes, champion and articulate and make sure those actions, but where policymakers can really come together is to remind everybody that this is deeper than the divisions. This is really about how do we come together so we can further the health and well-being of our communities.
Oh, nicely eloquated. Dr. Chen, what are your thoughts? Are there any recommendations for policies or ideas you have for legislative support that we state legislators can work with our local governments and healthcare providers?
Yeah, I think there are many things that legislators can do. First of all, I think it's important that legislators implement health in all policies. This is an approach that we know works to promote health equity. It integrates health into all our decisions and policymaking. Another thing that which, as I mentioned, NAPACSL already understands is you need to ensure that data is being collected. I know that in the healthcare systems, a lot of times they just have rudimentary, I mean, many of their systems were built for billing, so they don't particularly enter very good racial ethnic data, but when you want to address other social, economic, and environmental conditions, you should consider collecting income data, education data, data that's specific enough so that we can hotspot where they live. And lastly, they need to partner with community in everything that they do. It makes your work stronger, more relevant, and more effective. I know that with your organization's policies, I've mentioned the data disaggregation, the cultural competency, humility, language access, and addressing the social determinants of health. But one of the concepts I really encourage you to think about is the legislator as community leader, in addition to being a policymaker. So contact your state civil rights or immigrant or refugee office, ask them for a report. Convene a district meeting with AAPI community members, connect with APCHO to identify if there are AAPI serving community health centers in your district, connect with your state or local health department to discuss efforts to combat racism and how many of them have implement or passed resolutions declaring racism as a public health emergency, support federal legislation addressing hate or racism, check with hospital law enforcement and law enforcement collection of violence data and racial ethnic data. But as I mentioned earlier, social marketing is going to be really important, right? Education doesn't change behavior. Every smoker knows smoking is bad for them, but they still smoke. However, there is hope here because race is a social construct, right? It is not a biological determinant, it's a social construct. If it's a social construct, we have hope to reverse the harmful effects of racism. We can shift attitudes and behaviors, dismantle the institution and systems that perpetuate racism. And lastly, we have to address violence. And violence isn't just gang violence, it is bullying, it is domestic violence, it is robbery, it is all kinds of violence. The anti-Asian hate is only a piece of the violence. And if we don't take public health approaches to address violence, we will never be able to address the anti-Asian hate.
Thank you. Thank you both. Thank you, Dr. Shaw and Dr. Chen, for your work you do in the communities, but also, thank you for sharing your insights and suggestions with all of us today. On behalf of all of NAPACSL, we want to tell both of you this was very helpful and we appreciate you committing the time to spend with us today. I would like to turn the webinar back over to Representative Santos and Representative Lee. Thank you again.
Thank you, Representative Yamane, for helping moderate that. And so now I'll move on to the general Q&A for all of our presenter. Just wanted to acknowledge, the importance of data collection. And so just want to say thank you all for speaking to that. And maybe I'll kick it off real quickly. And if we don't want to get in depth in here, we could talk more offline. As a policymaker, one thing that I often struggle with in Minnesota, at least, is I want to collect data, but I don't know what is the type of data that we should be collecting. And so is there, like a general set of figures or data that you believe it's important for us to be aware of that we should be collecting right now as we move forward with regards to addressing, anti-Asian, biases and some of the other issues that we're seeing in our society today?
I think there's a good place to start. Talk to your public health department, right? And talk to your local university or school of public health. But I mentioned some, racial ethnic obviously is a clear one. If you want to look at some of the other, the socioeconomic environmental conditions, that's another one, right? But, there are some innovative things that take a little work. So for example, if you want to look at violence, if we didn't have Stop AAPI Hate, we wouldn't know a lot of the stuff, right? And if we look at just law enforcement data, they only have data if it's a serious crime or someone gets booked. However, there's this thing called the Cardiff model, which is a violence prevention model, where they say, if you look at the health system's data, if someone gets beaten up and they have a broken bone, the health system registers that. That person may not report it to police. If someone gets slashed by someone else at school who is carrying a knife, they'll show up in the ER or the doctor's office, get stitched up. That will show up in the health data, right? So there's this concept that if we can tap health data and combine it with law enforcement, data, that it really expands our ability to see how much violence is going on, right? And a lot of times we end up dealing with the end stage, what we call tertiary prevention public health. We need to deal with the secondary prevention, primary prevention. What are the indicators that might predict violence or susceptibility to mental injury, mental injury if people were subjected to violence, right? So these are just a little bit more upstream. We really need to be looking at that kind of data as well.
And Representative Lee, what I would just add on top of that is that it's really to encourage those federal agencies to not be in their silos. What's happening is that you've got, the health agencies, whether it's FDA or NIH or CDC or ASPR, they're all in their health silo, and then you have transportation, and then you have education. Everybody is in their silos, and what we have to remember is that when both strategies, funding, and data, when they get to federal alphabet soup agencies and ultimately to local, even down to community, that at the end of the day, it all comes together. And so education and transportation and housing and health, it all comes together. And so what we need to also encourage and require is crosswalk across these agencies for that data. It's not just the disaggregation, which is absolutely critical. It's not just the health and social. It's bringing all that together so there is meaningful work towards what are the issues and how do we address them collectively.
Thank you for those answers. And so I just want to say we have about maybe 7 minutes. And so if you could keep your remarks short, I apologize if I didn't bring that up before. And so we have a question from one of our members. Many of our healthcare workers are AAPI. How do they deal with racism from other persons of color?
I mean, I'll keep it short. I'll just say that first of all, you have to call it out. You have to know who you can trust. But when there's fear involved in this, it becomes really hard. But you have to call it out, and you have to ultimately go to someone or an entity, especially if it's in a healthcare system, who can actually then address it. Do not back down, because it will not just get worse for you, but that same individual will likely be doing that to others as well.
Yeah, I think this just reminds us that anyone can be racist, right? Asians can be racist, Black people can be racist, right? I mean, a lot of the anti-Asian hate is perpetuated by Black people, right? And it's so, of course, we have to support the people. We have to change the culture. We have to change the systems. Healthcare systems need to be creating safe spaces. They can't tolerate any kind of violence or hate. And they need to create things like affinity groups and places for people to be able to process their experiences.
All right, thank you for that. And so the next question is from Representative Santos. She said, quote, I am struck by STOP AAPI Hate's recommendation on prevention of incidents of anti-Asian bias and hate. What is the role of public health leaders in preventing these anti-Asian activities?
Well, I'll just say really quickly that prevention is really where public health feels that our biggest role is. That when you look at the healthcare system, it's the repair shop, or it's where things happen when something has gone wrong, or despite everything, things have occurred that way. And we really believe that those elements of looking at the sources of what's happening is about prevention. And that's where we see our role significantly. And then I think, as we talked about, articulating and then certainly making sure our resources are pointed towards, and really addressing the prevention aspects so that it's not after the fact. And I particularly want to call out for our children. This is very much about pediatric as well. Have to be thinking about our next generations and not just what's happening right now in our society.
Well, as I mentioned earlier, that is very fundamental to the work of public health, right? We work with populations on prevention. And when you look at the core functions of public health, which are assessment, policy development, and assurance, one of the first areas we can help is with the data. And Representative Lee, you asked about it earlier. What I forgot to mention was, let's not just look at hard numbers. Let's look at qualitative data as well. And this relates to what I said earlier about legislators should be working with their communities, talking with the communities. I can tell you that when we did one of our early community health assessments, before we had the hard data to show there was an opioid epidemic, people were telling us they were very worried. They were seeing their friends and neighbors getting addicted and dying of overdoses, right? So public health can help with the data. They can help with the data connection, with the community connections. And if your local health department's not engaged in community, push them to engage with the community in meaningful ways. And then we can help formulate the policies. Again, it is things like social marketing, policy systems, environmental change, linking with things like urban planning, transportation funding, built environment. This is where public health works all the time. And public health really doesn't have that much power, except our biggest power is convening people and bringing the partners together. Again, then going from there to work with the community and business, government, community to move the policy systems and environment.
So I don't see that we have any other questions, but we still have a few more minutes. And so I just want to piggyback on that point, Dr. Chen, and to the two of you in your leadership capacity. So how do we really advocate for all of these different investment into different areas of society that may not, when you think about public health, for me, I chair the capital budgeting. How do we make sure that capital budgeting, really takes into consideration our impact into public health? Vice versa, our budgets and education and some of the other budgetary items that we may not think will have health will have an impact on.
Well, I think the first thing I would say is that all those other areas do impact health. So please continue to fund the transportation and all that does impact end health. But we also have to make sure that the investment in public health is not just about healthcare delivery. We have to be really thinking beyond that, markedly beyond that. And really, at the end of the day, this is about how do we assure that a one-time investment is not where we stop, that this is a strategic, smart, and scalable way of looking at a long-term set of investments that can't do it right in the middle of a pandemic when everybody is just taxed right now with everything. We have to be thinking about strategically, what does this look like for the long run? And then the last thing I would say, and I'll turn it to Dr. Chen, is that we also as leaders need to be willing to put ourselves out there. We oftentimes don't. We don't say that this is wrong. We don't say on social media, we don't come to the assistance of each other when something is happening that's negative or nefarious. So we have to be also calling ourselves out to be responsible for not just ourselves and our well-being, but those around us.
Yeah, earlier I mentioned health in all policies, and as legislator, every bill you see has a fiscal note. Why does it not have a health note? Right, so our Board of Health passed a health in all policies resolution, and the city of Tacoma did as well. And there's what we call a health lens analysis tool on every resolution that comes in front of our board that is filled out. City of Tacoma, same thing. And it asks questions about what's the impact on health, has there been engagement of the community, right? You're used to this on a capital budget with a EIS, right? But why isn't there a HIS, a health impact study or something, right? But these can be fairly brief tools. So that's one strategy that you can ask to implement, or at least pilot, say, in one committee or one part of your legislature. But if you don't think about it, if you don't measure it, it doesn't get done, right? And that's why we have a fiscal note, because some policies sound great, but when you look at the cost, it's just not worth it, right? So same thing with health. And this shouldn't just be the end stage of saying, oh, we are or not going to do it. The health lens analysis tool can be used to help shape the legislation. But the initial assessment might not look that great, but it might point to areas where there's greater community engagement. You mitigate certain impacts, rewrite part of the legislation, and you run it through the health lens analysis tool again, and it'll come out with a higher score. That's what we want. We don't want it to be a barrier. We want it to help improve the process and the products that you all are sending through the legislatures.
Well, thank you both so very much. I'm really envious of Representative Santos, in having the two of you in her state. And so now I'll turn it over to Representative Santos.
Thank you, Representative Lee. I am very, very proud, as are my colleagues from Washington State who are also on the line. I do want to extend a final thank you to our presenters, Cynthia Choi from Stop AAPI Hate, Dr. Umair Shah, the director for the Washington State Department of Health, and Dr. Anthony Chen, the director for Tacoma Pierce County Public Health Department. I want to call out our colleague, Representative Teresa Ma from Illinois, because I just happened to receive in my personal inbox today a new report from CASL, the Chinese American Service League, where a nonprofit organization did a survey with results on the social determinants of health and the rise of mental health needs in her community. I think that's something that we could probably replicate. I want to thank also again our sponsor Amgen, and to each of you, thank you for participating in today's webinar. You can look forward to others in the future. And with that, I would say goodbye and happy holidays.
Thank you, everyone.